All right. Good afternoon. It's a pleasure to be here presenting today on the topic, very important topic of genetic testing in ovarian cancer. So my goals for today are to develop a common understanding of the rationale for genetic testing, to review the genetic mutations that are associated with ovarian cancer, to discuss the types of testing available, and to review Oncology Society guidelines for genetic testing. So while all cancers develop from pathogenic mutations in certain genes, not all of these mutations are inherited from a parent. BRCA1 and 2 have long been known to cause hereditary breast and ovarian cancer, but recent studies have demonstrated that other genes result in increased risk of ovarian cancers. This table highlights the genes that are currently considered to confer susceptibility to ovarian cancer. There's very strong evidence that RAD51C and RAD51D, as well as BRIP1 variants, lead to hereditary ovarian cancer. The Lynch syndrome genes also result in increased risk, though the actual lifetime risk varies significantly by the affected gene and can be anywhere from very close to the population risk of 1 to 2% for PMS2 all the way up to 20% or greater for MLH1 and SH2. And there may be a slightly increased risk of ovarian cancer with certain variants of PALB2, NBN, and ATM genes, although this is less clear. What all of these genes have in common is that they're all involved in DNA repair pathways, either homologous recombination or mismatch repair, and that is what leads to the susceptibility to ovarian cancer. So moving on to talk about the benefits of genetic testing. Historically, the primary indication for genetic testing was to identify familial cancer susceptibility and initiate cascade testing to ensure that relatives of our patients with ovarian cancer receive timely preventative care. But when mutations increase the risk for other cancers, we also need to be recommending additional preventative care, such as referral for breast or colon cancer screening. And this is really critically important now that a lot of our ovarian cancer patients are surviving longer. But most significantly, the strongest indication for genetic testing is that now in the era of PARP inhibitors, the results should be used to inform treatment decisions. And so I'm going to go into that a little bit more in detail. Can't really talk about genetic testing without talking about PARP inhibitors, though I'm not going to go into too much detail because we have another speaker talking about that right after. So treatment options for ovarian cancer are expanding and our patients are living longer as a result. This timeline shows all of the FDA approvals for treatment of ovarian cancer. Since 2014, there have been 11 new approvals and 8 of them are for PARP inhibitors. The first FDA approval for a PARP inhibitor was olaparib for BRCA mutated recurrent ovarian cancer, and that was in 2014. And then starting in the fall of 2018, we had the publication of 4 major trials of PARP inhibitors as first-line maintenance therapy after complete or partial response to platinum-based chemo. All 4 trials published their results within a 1-year period. First, there was SOLO-1 in December 2018, and then PRIMA and VALIA in September 2019, and then finally PAOLA in December 2019. In study after study of PARP inhibitors, both as maintenance after primary therapy and in the recurrent setting, we see truly remarkable improvements in survival for patients with BRCA mutations or who are otherwise homologous recombination deficient. But there's a much more marginal benefit for patients who are homologous recombination proficient. And so genetic testing is critical in helping us to select and counsel patients on the likelihood of benefit from PARP inhibitor therapy. To explain why this is, PARP inhibitors prevent the repair of single-stranded DNA breaks by disrupting base excision repair and also causing PARP1 trapping. This results in DNA double-strand breaks. Cells that are homologous recombination deficient are unable to repair double-strand breaks, and that results in cell death. But cells with intact homologous recombination are able to repair those double-strand breaks, resulting in cell survival. Let's talk about how common these mutations are. While the frequency of mutations in ovarian cancer varies by population, So we know that certain populations, like Ashkenazi Jews, have a higher incidence. So certain studies in different populations are going to vary slightly. But overall, we think that that there are germline BRCA mutations in about 13 to 17% of patients with ovarian cancer, and somatic mutations in an additional 6%. There are also possibly germline mutations in other genes in the homologous recombination pathway. Probably about 4% of ovarian cancers will have a germline mutation in one of those other homologous recombination genes. And then another 2 to 3% will have somatic mutations in those genes. And then there's another 10% of tumors that are likely to have BRCA1 promoter methylation that inactivates the BRCA1. And so the best estimates are that greater than 40% of patients will have germline or somatic mutations or epigenetic changes that may confer sensitivity to PARP inhibitors. So these mutations can occur across all epithelial ovarian cancer tumor histology. High-grade serous is the most common histology associated with germline BRCA1 and 2 mutations, but germline mutations have been identified in all epithelial histologies except for mucinous. And then patients with Lynch syndrome are more likely to have non-serous epithelial ovarian cancer, so clear cell, endometrioid, and mucinous. Germline, so when we send a patient for genetic testing or when we order a genetic test, we like to think that that result, either positive or negative, is reproducible no matter what test we order. And for germline testing, that tends to be true. It's well established and highly reproducible. DNA is extracted from healthy cells, and so it's a relatively much more straightforward process. And there's robust data supporting the prognostic and predictive value of various germline mutations. Still, not all mutations have been classified as benign or pathogenic, and variants of unknown significance present an area of uncertainty for our patients. But in contrast, somatic testing is much newer and less reproducible. Tumors are very heterogeneous collections of normal and malignant cells, and multiple subclones can be found in a given individual tumor. And as a result, the DNA extraction process can significantly affect the results. So, in addition, there's no standard method for analyzing data and predicting pathogenicity. With somatic testing, there can also be differences in what we're actually testing. So we can look at both the presence of BRCA mutations within the tumor, as well as the downstream results of those mutations. Without BRCA, cells lose certain DNA repair abilities, and so we see, as a result, genomic instability. There are 3 types of genomic instability that have been described in this setting. There's loss of heterozygosity, which is the presence of a single allele rather than having 2 alleles. There's telomeric allelic imbalance, which is a discrepancy in the number of alleles in the telomere, so the end of the chromosomes. And then there are large-scale state transitions, which is when there's transition points between regions of abnormal and normal DNA. Tests that evaluate for these are often referred to as SCAR assays because they are looking for the permanent DNA damage that occurs when DNA repair systems are knocked out. So somatic tests vary significantly by assay. There are many commercially available options for somatic testing, but what testing is performed varies with each test. Most of them use some form of next-generation sequencing with a multi-gene panel. However, which genes are included is different with every test. Second, they can assess the downstream impact of the homologous recombination deficiency, so they can include that SCAR assay that I talked about, but which of these 3 changes they're actually looking for varies from test to test. Finally, tumor testing can detect epigenetic changes such as methylation of BRCA1 and RAD51C that result in loss of function of these proteins. So figuring out which of these, the other area of uncertainty is that we aren't entirely certain which of these are actually biomarkers for response to PARP therapy. We certainly know that loss of BRCA1 and 2 genes is a biomarker for PARP response to PARP inhibitors. But the data is a little bit more murky for some of the other types of testing. So talking about how we actually, so we have somatic testing, we have germline testing, how we actually sequence those. There are 3 different strategies for sequencing that have been proposed. We can, let's see. So we can first do somatic testing for everybody, and then if we find a BRCA mutation, we can refer those patients for germline testing. We can have germline testing for everybody, and then perform somatic testing only for patients who have a normal result. Or finally, we can do simultaneous germline and somatic testing. And the simultaneous testing is, of course, going to be the most expensive because we're doing both tests for all of our patients. The somatic testing first is going to be the most cost-effective, but unfortunately, it's the least sensitive, and there's general consensus that we should not be doing somatic testing only. And the reason for that is that when we rely on somatic testing to identify patients for reflex genetic testing, we may miss up to about 5% of patients who have germline pathogenic mutations. This was shown clearly in the SOLO-1 trial, where 100% of patients had germline BRCA mutations, but there were 5% who had either only who were either BRCA wild type or who had a variant of unknown significance on their somatic tumor testing. So the sensitivity of most tumor testing is lower than that for dedicated germline tests. So which patients with ovarian cancer should have germline testing? We see that there's consensus among all of the leading oncology societies that all patients with epithelial ovarian cancer should have germline testing regardless of age or family history. When should germline testing be performed? Patients should be offered germline testing at the time of diagnosis. So this is a really good, this ASCO guideline was published 2 years ago. It's a great summary of all the evidence, but very clearly we should be testing everybody at the time of diagnosis so that that information can be used to guide treatment decisions. When should somatic testing be performed? Patients without BRCA1 or 2 pathogenic mutations should undergo somatic testing at diagnosis. And then for patients who've completed primary therapy, we can delay the somatic testing until recurrence, because that's when we may be making treatment decisions with that information. What about beyond BRCA? So given the high rate of mismatch repair deficiency in those non-serous histologies, we should be offering our patients with clear cell endometrioid or mucinous histology mismatch repair testing at diagnosis. And then I would say the kind of correlate of this is that all patients probably should be offered mismatch repair testing at recurrence, because there's an FDA indication for use of immunotherapy in patients who have mismatch repair deficient solid tumors, and they would be potentially eligible for that therapy. So finally, it's important to note that there are significant disparities in rates of genetic testing. In this paper that was published in 2019, Curian and colleagues performed a study using SEER data of all women over 20 diagnosed with breast and ovarian cancer in 2013 and 2014. That was before we had PARPs, and so it was before that data was really critical for making treatment decisions, again, mostly used just for cascade testing purposes. But of 6,000 patients, only 31% had had genetic testing, and the rate of testing was lower in Black and Hispanic patients compared to white patients. And so while this data is based on the pre-PARP era, there have been plenty of abstracts. I haven't found any papers, but plenty of abstracts published that demonstrate that this is unfortunately a persistent disparity. So what are barriers to genetic testing? I think probably all of us who refer patients have experienced challenges and delays. So kind of in terms of what our patients experience, the cost of testing and whether their insurance and to what degree their insurance covers it can vary. And so patients may either decline or delay genetics counseling and or testing because of those costs. When we are providing patient-centered care to our patients and focusing on what is kind of most important to them in each visit, sometimes that may mean that we delay discussion of genetic testing at the initial visit or at a post-op visit because there are other pressing concerns. There's also, I know at my current institution as well as the last one that I was at, we had both have had a big backlog in scheduling consultations with and testing because we just don't have enough genetic counselors. And then there's scheduling logistics for patients, and the kind of cost of an additional visit may be really challenging for patients who are already coming frequently for medical care, particularly those who come from long distances or who have the least resources. And then for those of us who've kind of looked at other strategies like embedding a genetics counselor in the gyne clinic, it's often more difficult than it has been in other settings or in other cancer types because we have a relatively low volume of patients who need testing. So what are solutions to ensure that we do kind of meet that standard of providing genetic testing for 100% of our patients with epithelial ovarian cancer? First, I would encourage you to identify a process for genetics referral and somatic testing that works for your practice. I work in a couple of different settings, and this is different in each of those settings, and so I think it really has to be individualized. Next, I would say it's critical to track or audit your performance to identify where gaps exist. So having some process that you do this formally to make sure that we are offering, referring, and then completing testing for all of our patients. And then finally, there's this kind of streamlining testing services is being evaluated in lots of different institutions, trying to figure out if we can, rather than sending everybody for genetics counseling and then testing, whether we can give more of a brief counseling with testing provided in the oncology office, followed by referral for complete genetic counseling for the patients who test positive, who are identified to have a pathogenic germline variant. And there's been one trial of this published a couple years ago in gynecologic oncology. That was in within the Kaiser Health Network, where they have kind of some advantages that make that possible. I think rolling this out, I've tried to do it, and it's a little bit more challenging logistically, but hopefully with more and better resources, it may be something that's a reality at some point. The kind of barriers, making sure that we do this in a way where we're protected medico-legally, where we're adequately letting patients know exactly what is going to be done, and that we are still ensuring that they receive the full genetic counseling that they should receive. So that is all I have today, and I'd be happy to take any questions.
Thank you. Great reminder that we all need to be testing. This isn't a question as much as it is a comment. Within our group, we did a very simple quality project, really looking at diagnosis of ovarian cancer, who had genetic testing. Really simple to find those gaps like you were talking about. One thing that we found to be very helpful is kind of taking your last point, we had our genetics counselor actually record a full sort of education session. It's maybe 10 minutes. And then whenever a patient was needing testing or had that new diagnosis, we had them watch the video, did the testing, and then like you said, the positive results would then go back to the counselor. So take advantage of technology too. That has been really, really helpful. We just kind of kept it on an iPad and patients would watch it so they could understand what was happening.
Yeah, I think that's a wonderful model. I'd love to have resources that were just widely available like that so that they could be rolled out. We don't have it yet, but hopefully.
We do have a question from the virtual audience that says, can you infer about a germline mutation on tissue NGS report, for example, based on the BAF value of a BRCA mutation that is identified on the report?
So, so I don't know. I think, you know, the standard of care, if you have a if you have a mutation, a variant identified on a tumor testing, would still be to refer for genetic counseling. I think there's not a way to be certain. A lot of times, if you look at studies that compare those results, there is a lot of consistency across testing, but certainly the somatic test will miss patients who have a pathogenic variant, as well as identify mutations that are truly only present in that tumor. And so to know which of those it is, patients should have germline testing.
Wonderful. Thank you so much.
Okay, thank you.